So let's start with the gastroenterology. The topic, the first chapter we are gonna start is irritable bowel syndrome. And what is irritable bowel syndrome? It's a functional bowel disorder, the reaction of GI system to stress. What are the associations of irritable bowel syndrome? Lactose intolerance, celiac disease, fibromyalgia, chronic fatigue syndrome, and generalized anxiety disorder. How the patient present? How the patient of IBD present? Gender, it is most common in female than male. Obviously we know females are prone to more stress compared to male. Then age, more less than 45 years of age. Pain, abdomen, one episode per week for more than or equal to 3 months, with change in the stool frequency, change in the stool form, that is appearance, unrelated to defecation. What are the sites? The crampy lower abdomen. The patient will present with crampy lower abdomen. Then frequency, it is episodic. Usually in 1 week, one per week. The frequency is episodic, one per week. What are the aggravating factors? Stress, eating. Relieving factors, defecation. Upon stress or eating, the irritable bowel syndrome aggravates. Upon defecation, relieving, there will be relieving of the pain. Then what else they'll present with? Abdominal distension and bleaching, dyspepsia, heat burn, nausea and vomiting, and altered bowel habits. What are altered bowel habits like? Diarrhea predominant, diarrhea, constipation predominant, diarrhea predominant, constipation predominant, and mixed. Negative diagnosis of IBS. The IBS patients will never present with nocturnal diarrhea, fever, weight loss and anemia, malabsorption, increased erythrocyte sedimentation rate, steatorrhea, and blood in stools. What is the pathophysiology behind IBD? Maybe due to visceral hypersensitivity. Visceral hypersensitivity means even if there is a minimal rectal distension, this stimulates the pain receptor, which enhance this due to enhanced sensitivity. Increased serotonin containing enterochromaffin cells, increased colonic motor potential, central activation of cingulate cortex and vanilloid channels. These are responsible for IBS, irritable bowel syndrome. How to manage irritable bowel syndrome? It is either through diet and lifestyle modification. 70% cases, in 70% case there will be improvement. What can be done? Walking for more than 6,000 to 8,000 steps per day. Then diet, reduce the FODMAPs. FODMAPs means fermentable oligo-di-monosaccharides and polyp. What are sources of FODMAPs? Apple, mango, wheat, honey, legume, cauliflowers, and etc. Still more. These are called as fermentable oligo-di-monosaccharides and polyps. Only 30% cases there will be no improvement. Then we can go to medical care. What happens in FODMAPs? If in small intestine, due to FODMAPs, it absorbs water into the bowel, leading to diarrhea. And in large intestine, there will be a bacterial fermentation of FODMAPs, which leads to bloating, distension, flatulence, abdominal pain, and constipation. Medical treatment. What treatment can be given to IBS? Diarrhea predominant and constipation predominant. For diarrhea predominant, you have to give loperamide. Antispasmodic 30 minutes before the food. Antidepressants and obsolete drug. Constipation predominant, you can give stool bulking agents like psyllium husk, pegylated polyethylene glycol PEG, polyethylene glycol laxatives. Lubiprostone, it is a bicyclic fatty acid which is a chloride channel activator. Linaclotide is a guanine cyclase agonist. Tenapanor, which is sodium and hydrogen exchange blocker. For diarrhenic, some other drugs are aldosterone, which is serotonin antagonist. The side effects of aldosterone is ischemic colitis. Elixadolin, which is mu and kappa agonist and delta antagonist. The side effects are pancreatitis. Tegaserod, the side effects are cardiac toxicity. Note: the effectiveness of antibiotics, prebiotics and probiotics are not determined. It is not very useful.